Chris Crow, family physician by training and president of Catalyst Health Network. I'm joined by Mr. Jed Constance, who is a leader in health system change, and also by Alyssa Abel, who's a fourth-year student at Albany Medical Center. So I want to thank everyone for joining with this call this morning.
Good.
So
thanks, Larry.
Dr. Crow, could you start off by giving a little background about yourself?
Sure. I'm located in North Texas, and I'm a family physician by training. To back up just a second, I grew up in Hillsboro, Texas, which is a small town about an hour south of Dallas area. We had 3 primary care physicians, all family physicians at the time when I was growing up, and they really led the community in more ways than just the exam room. They were the mayor and the head of the city council and the head of the school board, and of course on the sidelines at all the football games where the entire town went to on Friday nights, and each of them, I think, led the Presbyterian Church, the Baptist Church, and the Methodist Church. So they were mentors of mine, and I didn't really realize it as I was young, but I did decide to go to medical school in no small part because as I looked around my small community, I saw who I admired the most, and that's who I admired the most for what they were doing to help our community in more ways than one. And so that took me on the long education train that Allie is in the middle of right now to go to medical school, which I got in by the skin of my teeth at University of Texas in San Antonio, and then went on and trained at Memorial Hermann as from a family practice residency training. And along the way, shortly after, opened up my own shingle with my partner up in Plano, Texas, and got an executive MBA from University of Texas to help really give me some business background, because I was a zoology major, and I'm not really sure what zoology is, but that's what got me through to medical school as a major. And the MBA actually was kind of like taking a blindfold off, and I was able to see concepts and understand jargon that I didn't have access to before, because zoology, you don't have those type of classes. But the world started to make a lot more sense to me once I started taking these business school classes and was working with peers who are outside the medical industry, healthcare industry, and other things, and other industries, to be able to learn from some of the things that were their challenges and how they solved problems. And it quickly allowed me to start to envision how we could have a better healthcare delivery system. And I have figured out that I'm more of a strategic systems thinker and like to build systems of care that can impact lots and lots of people rather than the 25 people I might see in an exam room today. How can I help 2,500 physicians with their 25 people in the exam room today? And then so on and so on. How do you connect the healthcare delivery system into a community? And ultimately kind of hearkening back to my Hillsboro days of my role that I can play as more than just a family physician to help our communities thrive. And so at Catalyst Health Network, we are trying to certainly as our purpose every single day is to help our communities thrive, and we happen to do it through better healthcare delivery.
So can you give us, describe Catalyst Healthcare? What does it look like?
So Catalyst Health Network is right now it's growing very fast. We're getting close to 1,000 primary care physicians in a URAC accredited network. And for those of you who don't know what URAC is, you've heard of NCQA and probably the medical home model if you're in our industry. And URAC is an accreditation body that is accrediting networks to prove that they're, or at least certify that they're clinically integrated, following the FTC guidelines around clinical integration. We also have care management as a certification, as well as transitions of care, and we'll be adding community pharmacy as well later in the year. And there's no one in the country who has that trifecta of certifications, because we believe we are building certainly a care model, and very different than most of the networks that you hear about nationally that are built around health systems and that are built around just the MSSP model. We believe in a holistic model that physicians and their practices can use to extend their care that's in the offices into a virtual care team model that has technology that communicates and reporting that informs, so patients and physicians can have an augmented relationship where there is already more trust than anywhere else in the healthcare system, but to make that even more sticky so you can get better behavioral change and ultimately better outcomes to reach the quad aim that we're all elusively searching for. And so these very different than everybody else. We are only primary care physicians as members. Again, we have close to 1,000. We started in North Texas, where we have well over half of those 1,000 are in North Texas, but we're now in East Texas. We're now in South and Central Texas as well. And these are all independent physicians for the most part, of 1 to 2 doctor practices up to smaller health systems that have 50 primary care in their groups and things like that have joined us as well. We do only value-based care contracting for all products, so Medicare, Medicare Advantage, and obviously the commercial carriers of Blue Cross, United, Cigna, and Aetna. Right now we care for something in those practices, something close to just shy of 1.5 million lives, and we've been at it for about 4 or 5 years now. And after our first 3.5 or so performance years, I think this year we'll be eclipsing the 100 million in savings, which is probably a number that I don't think anybody else has reached from a non-health system network standpoint. So that's just a little bit about us.
So could you comment on, when you talk about holistic care, what does that mean to you?
It means a lot of things, Larry, but it starts with the idea that we as humans are way more than just a physical set of diagnoses and body parts, and that we have this emotional, mental, spiritual, social components as well that actually drive our behavior and ultimately outcomes. And outcomes being things like how am I able to live my life, and what is the allocation of time and money that goes to keeping my physical health up to par. And so when we think about the whole person, our care, it's fashionable to talk about social determinants of health right now, especially in the lower income populations, but no one's walking around doing vital sign checks on social determinants for people in that way. It's more of understanding how to talk to people, how to find out the most important question of what matters to people rather than what's the matter. We're taught in medical school to start with a chief complaint, and we don't think that's actually the exact right answer. We think we need to ask people what matters to them most, and then work from there. And so our core belief is that relationships matter. And so we want to make sure our relationship between the physician and the patient is held sacred, and that everything that we build around it, from our care team, which is well over 100 right now, that are nurses and social workers and pharmacists and pharmacy techs and care coordinators and referral managers and educators and health coaches, all of those are there to actually help augment that physician-patient relationship, and that ultimately you extend that trust from that relationship out to where you can have conversations and interactions, not just in the exam room. In fact, the exam room becomes the minority of the interactions, rather than using technology as well as other means, just plain old telephone, to speak with people and get to know them better and figure out what matters to them, to where we can actually help come alongside of them to help them make better healthcare decisions and with their time and with their money. And so that's more of how we think about it from a holistic standpoint.
Okay. So you've got a very large network of physicians and practices. How do you make sure or support their approach to care, so that what you just described sounds very exciting, very holistic, very much in line with what George Engel many years ago talked about as the biopsychosocial model. But how do you make sure that the practices that sign up and join your network are in fact doing that?
Yeah, it's a great question, Larry, and it is the issue that we have struggled with the most, and we'll call that the physician and the practice engagement, which is then followed by the patient engagement. But if you have physician engagement, the patient engagement, what we found, actually follows pretty quickly if they are in relationship with each other.
Mm-hmm.
And I'm not going to sugarcoat this, but having a crisis has exponentially increased the physician practice engagement in what we're doing and the model we've built, because everyone is starting to see the future, and the model that we have built actually looks like what is likely going to be the future. And so what we do, but if you back that up a couple of years, Larry, and say, how do we think about that? Is one, I'm a physician, so we build everything through the lens of what will engage the physician, and here's the things that matter most. And not necessarily in this order. It depends on the physician and how they have their priorities in the practice. Everything has to be a net positive financially. Everything has to be a net positive on time and that they are having to put into something from a work standpoint. And everything has to have a net positive clinically. And finally, everything has to have a net positive from an ego standpoint. And what do I mean by ego standpoint? Is they got to feel like they're getting good feedback from any of the resources or tools or people or technology that we're integrating into the practice, that when themselves, their staff, and their patients interact with it, they're getting positive feedback back to reinforce that behavior, to continuously use and engage with those tools, services, as we bring new things on board. So the other three things I think are pretty self-evident. So we have to make sure that everything goes through that frame that we bring out, that it has to hit all of those marks in some way, shape, or form. Because if you build something that hits all but clinically, that doesn't work. If you build something that makes everything work except for they lose money, that doesn't work. If you build something that says it works great, but they have to spend an extra hour a day on it, that doesn't work, right? So you have to make sure you're building things that fit into that filter, and then you go from there from an engagement standpoint. And the crisis certainly has increased their engagement more than ever. They're relying on us to not only bring them a different care model, but we also are able to bring them a differentiated business model. And we can talk about that in a second if you like. But that's kind of that's the current wave we're at right now. Is we're bringing to bear something that's a part of our business that's been there for 6 years. That we have private practices that are clients on what we call our practice services side. That's more on the business side, IT, EMR, revenue cycle, financial performance, strategy, that we do directly to individual practices. That's not been part of Catalyst Health Network as a whole from a clinically integrated network standpoint. But that's now in this crisis where every practice is wondering if they're going to have continuity and going to stay open. We're able to bring those services to bear as well in this time.
That's fantastic. Since you raised the issue of the business model, do you want to take a little time to describe that?
Yeah. So once we saw, there's a lot of analogies in family medicine. You're constantly trying to explain something that's complex to people in a more simple ways, using metaphor and analogy. So there's a lot of good ones to use right now. But one is from a hurricane standpoint, we're able to look out on the radar and predict, how many days it is and where a hurricane might hit along the Gulf Coast, let's say. And as it gets closer and closer, it becomes more evident of where it's going to hit and the strength and potential damage. So about 3 weeks ago, we started to realize that there was a hurricane out there, and it was going to hit our practices with a brunt that they have never seen in their careers. And so we started about 2 weeks ago with several things. We started a hotline for patients because we had to actually act as the public health here in North Texas. We stood up drive-through testing things we never knew how to do, but we've learned how to do that, and we're doing hundreds a day now to protect our practices so they wouldn't lose physicians and staff to quarantine. So we've been able to keep everyone out of quarantine because of these drive-through testings that we stood up immediately. We then immediately went from that to telehealth. 15% of our network of primary care physicians and providers were on telehealth platforms a month ago, seeing about 1% of their volume through telehealth. Today, we're at 92% of all of our practices are on a myriad of telehealth platforms that we've helped them get up on, and well over half of their visits are now on telehealth, all the way up to 100% in some cases. So that is a massive shift that we've been able to pull off, and we don't own these practices. This is a very important point. These are independent practices with different EMRs that are members of Catalyst, and they are now engaged in such a way because their life and their business depends on it, as well as their staff's lives and jobs, and as well as the patients that they care for. In a moment when, we're talking about ICUs and ventilators and trying to think about, are we going to have enough? The primary care workforce is the front lines that cannot go down in this moment, and we have to stay up for our communities to take care of those individuals that are chronically ill and elderly and immunocompromised already, as we always do, or we will compound this felony in the ICUs and in the hospitals. So we are a critical piece right now in this moment that I think we're becoming more and more aware of. And so as the business model has moved to virtual, and we've gotten telehealth parity really on everything we do, we're now beginning to imagine, what does this look like on the other side? And because I don't think we're going to ever come back to the level of office visits that we've had before. We already have all of our workers off-site at Catalyst Health Network. Our entire care team is working remote. The only thing we have going still in the office is our central fill pharmacy that's doing over 1,000 scripts a day and growing to get medications directly couriered to patients so they don't have to get out to get to the chain stores and put themselves at risk. And so that's where we're moving. And so this whole idea of a more virtualized but connected and expanded with a care team model around telehealth and telespecialty is in being able to track smart referrals over technology rather than the old business cards. We have over 6,500 specialists and services mapped in North Texas alone that we have on a single communication platform where all of our referrals are tracked. Just like Amazon tracks toothpaste and toilet paper, we're now doing that with humans, which we obviously think is pretty important. And so on the other side of this, we are already working on more prospective payment models with the carriers as not only a cash infusion for now, but also something to move to so that we're not stuck in this fee-for-service reactive transactional model when actually primary care delivery is relational and long-term and proactive. We need to get a financing model that matches this care delivery model that actually will produce the quadruple aim. In the short term, though, Larry, there's this time where we've been worrying about having the old 2 foot, 1 foot in each canoe metaphor, and that it's been taking for so long. Okay, we are ripping the Band-Aid off in a matter of weeks to get to the other side of this. And so how do you bridge the cash flow in practices? And so we are building toolkits for practices. We're building 90-day plans to help them think about this with all of our members. We have, several hundred, maybe at not quite 1,000 physicians and practices across Texas and Oklahoma of specialists and primary care that we are their ongoing advisors, whether it be only financial and strategic, but also could be technological with their EMR, IT, and revenue cycle as well. And we provide them a lot of tools and insight to run their businesses like any smart business would. And we are now bringing that to bear into the Catalyst Health Network and helping 100% of our practices have visibility to our capabilities and our insight and guidance and building models for them to understand what happens over the next 1 to 2 to 3 to however many months. We're making a 90-day plan right now for cash flow. What are your ways to help revenue from a standpoint of we've now stood up text messaging that we can do for the practices to get to the high-risk patients and get them to do a televisit? How do you segregate the population and look at who else is at risk? How do you do more advanced directives in this moment from a telehealth standpoint? How do you keep up with your depressed patients in a different way than you could have before when the office visit model was the only way you had? How do you think about taking care of your chronic disease patients? How do we put those people in front of you, as well as be available and open for all the COVID type cases and concerns that are coming through? How are we expanding the capacity of the PCP in their offices in a moment when the community needs it, and in a moment, though, when their revenue is going down because the office visit business model is drying up? We have well over half, if not 75% reduction in actual office visits right now. So this is a time when their revenue is going to dip to 50% or below of what they've been used to having. And we're a very high fixed cost business. Our prices are set by the government and the commercial carriers, and so we can't wiggle in that way. And we're not immune to the small business of America crisis that's happening right now. And so we are putting all of our efforts and all of our career experience on the line right here, right now, to help these people walk through the 90-day period and have them think about where their cash options are, how to add more value to the community that also will bring revenue through telehealth, how to help support them with the carriers and Medicare and what's going on at the COVID relief right now, to try to help get some infusion into these practices. We know the hospitals are getting bailouts, but how do we keep this front line open? Because it's absolutely connected to what's going to happen in the hospitals. And then finally, actually, if you need outside capital, is we're creating kits to work quickly, not only with the small business administration loans that are out there, but more importantly, with some of the other banks out there that are willing in this moment to understand the need of physicians to have not only a line of credit, but potentially a loan. We're creating fast track loans for physicians if needed as not only a last resort, but a likely piece of the strategy of how to make it through 90 days. I would say that there's not another network out there in the country who has that capability to bring that to bear immediately. That's happening over about a 3-day period. And next week, every one of our physician practices across our network will have at a minimum a 30-minute consult to be able to walk through a cash model that they can put in from some of their data that they're seeing, and let us help them, give them guidance on, based on their own priorities in their own context, in their own community, how we can help them. That's our ways of helping communities thrive in this moment. That's my way of being the mayor and the city council and the sidelines and the head of the Presbyterian Church, to make sure that we're helping our communities thrive, is keeping the primary care front lines open and shifting from a clinical focus, which these physicians got. They got the clinical focus in the moment, but how do we help them on the business focus, which is not 99% of them don't have that acumen.
Chris, I just have to tell you that this is just amazing what I'm hearing, and I just have to commend what you've built and what you're doing. This literally will save lives, as I think you know. Could you speak to the culture of your organization?
You bet.
You're the chief mover, the chief driver of the development, but how do you build a culture within an organization like this so that it can thrive and sustain and thrive?
Yeah, thank you for asking that question, because we think that is the competitive advantage and in this moment, more than competitive, it's a business continuity requirement, is to have a culture, and we talk a lot about leaders get the organizations they deserve. And again, my background that you asked for the first question about Hillsboro, Texas, matters a lot in this moment, in my experiences and how we are built, and my whole path in medicine to understand how messed up the system is, or maybe how perfectly built it is to get the results we get, and be able to have visions of what the future could look like, and allowing me to walk that walk to get to here. So our purpose, stated every single day, almost every single meeting that we're in, is we are in the business of helping our communities thrive. We think there are 4 pillars to any community, and that is healthcare, that is education, that is civic government, and that's jobs. And we have to have a balance in those. And there's other important things. I mean, transportation, infrastructure. I mean, there's lots of other things. But if you want a community to thrive, you have to have balance in those. And in my particular community where I've started my business in the North Texas area, it has one of the worst healthcare costs in the country. And so we took it upon ourselves to help save the independent practice of medicine about 7 or 8 years ago, because we saw in our early PCMH models when I was practicing at Village Health Partners that the independents cost about 30% less than these large integrated hospital systems. And you would also see that when the buying was happening and consolidation was happening, which I'm fearful is going to start again after this, that you were seeing a increase of price for quote unquote same store sales of services because of the hospital's higher rates. So the communities were getting doubly taxed in this consolidation, that there was a higher price point and there was actually a lower productivity once physicians became employed. And so we wanted to save our communities. So when you have a purpose that's deep in your bones, and you start to spread that to like-minded people who see and understand that problem and want to spend their time and energy week after week to make a dent in that, you get a pretty darn strong culture. After your purpose is you get to what are your core values, what's important in how you operate. And number one, I had already mentioned, is that relationships matter. We think relationships drive the world, and we think honoring relationships and building trust is the most important thing we can do in any business, but certainly in healthcare. The rest of our core values include being purpose-driven. As I've mentioned, we serve others first, and we inspire creativity. That last one about inspire creativity is what is so core to us. It's what allowed us to stand up drive-through testing, do telehealth, pivot financial information into our network, and do a lot of the other things we've done, such as the 6500 connectivity on the communication platform, bringing pharmacy and into the care team. All of those things are creative things that we've done that I don't think has been replicated across, and they're all to serve that purpose of helping communities thrive. So you start with a strong purpose. You start with the core values, which, by the way, were built by our people. I've taken many through this exercise before, but I waited for a couple of years, and about 3 or 4 years ago, we let our people decide what our core values are by walking through them, and these are the ones that came out. I didn't state these someday on a manifesto. I didn't decide what our core values did. I did decide what our purpose was going to be when I started our company. And if you have a really, really good culture, then it will absolutely act as a magnet for people that want to follow along and be a part of this movement. And it'll absolutely act as a deterrent for people who don't want to do that kind of work, which is equally important, to not have a lot of people in your organization that aren't following along in the purpose. Because the discretionary effort you get from people when they want to follow your purpose is your competitive advantage. Every morning right now, all of our telehealth, all of our workers are now off site. We have a 15-minute town hall every morning where I see close to 200 faces on a Zoom call, which, by the way, I can't say enough great things about Zoom in this moment, where we visit with each other, we connect with each other, we talk about the day, and that is absolutely everyone's highlight of the day. And the comments that we get, and the hey, we'll toe the line, and hey, people even saying, hey, if I need to go out without pay for a while, we're doing the most important work. We're out here, we're front line. Even if we're not on the front line, we're supporting the front line. And that sense of purpose is and core values is what allows us to propel and expand our impact across Catalyst Health Network. And now, by the way, we're putting a lot of our content out to be freeware, to be able to get to as many people as possible. The Texas Academy of Family Physicians has begun to put stuff out. We're doing quick little podcasts with them. That's been picked up by others around the country. We had the Mississippi Medical Association call yesterday, and they want our content. And we're sharing and sharing and sharing. You don't have to be a Catalyst member at this point to get invited to our daily webinars and to get in our daily care alerts that we're giving deep information. I had a Catalyst board meeting last night, which is 10 physicians on our board, and they all spoke of how their entire practice operations is now stopping every day at noon because the most important part of their day is the webinar that Catalyst is bringing out information to them for their practice. They find it the most valuable thing in their day-to-day right now that they're stopping everything to make sure that everyone is listening in. So just an amazing amount of engagement that we're seeing right now to your, I think, second or third question, Larry, because of this crisis that has allowed us to really pull together and really realize how much we need each other. And I think we're finding that out globally, that we are all connected, and this whole idea of individual and want it my way has its limits, and is not sustainable in crisis. And so our idea of, yes, we have to be physically distanced, but no, we don't actually have to be socially distanced. We really do not like that term. I'm pretty outspoken in the media about that right now. We believe in social connection, not social distancing, but we do believe in physical distancing. So you're getting a lot of my soapbox things right now while we're in a crisis.
Well, this is exactly what I was hoping for. What really impresses me, Chris, is I've been hanging out with family docs and the healthcare system for many decades, and you have brought together both the organizational development approach, where you have a clear purpose and clear set of core values, and you've blended that with the family physician primary care, really approach to individual care and community development in a way that I'm not aware of anywhere else in the country. So I just want to commend you for you and your team, because I know it's a team of people that does this. It's just awesome what you've done. I'm going to turn to Jed and Allie and ask if you may have questions.
Well, Larry, let me echo what you just said and add a component, which I think is absolutely critical, in the sense that, Dr. Crow, you have discovered the true both business model and business case, or business case and business model for primary care. Maybe not the only one, but certainly an important one that addresses that. You said it earlier in your comments that primary care, they're businesses. They are in many cases small businesses. And I, in my efforts over the past 40 years as I've evolved here, have truly come to understand that unless and until there are folks like you who are able to stand up primary care in a way that makes the business case both recognizable and worthy of investment from those who buy care, that's important. And so my question is, how did you come to this realization of the business case for primary care?
Well, I would say that there's not a moment, but there's a series of moments in my memory that I can draw upon, that I've hit on a couple of those already. It's just your experience, our childhoods and where we're born, and what was the experience of your childhood matters a lot. And I think I already detailed that. I think another big aha moment was around 2010, about a decade ago, when we were doing early medical home contracting when I was at Village Health Partners, which was the first NCQA level 3 medical home in the entire U.S. outside of the countries, I think in 2007. And so we started doing medical home contracts in the state of Texas with the Blues, United, Cignas, and Aetnas. We were the first in many of those cases. And we were starting to see that data. And I was starting to then appreciate the impact of what a good primary care relationship could mean, even though most of our market was in PPOs, which unfortunately didn't tie to a PCP at the time. Of course, still doesn't, but the power of that relationship, and how there was all these other businesses and technologies and non immediate value chain players, whether it be benefit consultants or insurance companies or technology companies who were trying to jump in and engage patients to help them with the total cost of care, when you had the best weapon, or in my case, what I would call the best relationship with the primary care physicians if they were connected to them, because they're longitudinal and not transactional. and didn't matter where their job was from year to year or what their insurance coverage was year to year. What remained the same was the primary care physician. And looking at the data, I was able to see that how a good primary care physician was able to really keep people healthier and have a lower cost. And so that seemed to be a little bit of a silver bullet, and which pivoted us into ultimately creating the companies that we've been discussing today. Because, and we now know that primary care physicians, if you have one, you live longer. You spend less money on healthcare, and you have more good days at work than bad days. I mean, that's a pretty significant outcome that's reproducible worldwide. So why wouldn't we prescribe that for everyone? I know the DPC movement has been a really great thing, maybe, with all these physicians taking on 500 or 600 patients. I find it fairly problematic. I find it very much provider centric, wrapped into patient centric marketing, because we actually need our physicians, and how we're thinking about our model is the exact opposite. How can we extend through a care team model our physicians to be able to take care of more and more patients in a systematic business supported way through their relationships to actually get what the country needs. And we need more primary care physician access. And if we don't, you're going to have all these third-party businesses pop up, whether that's retail or whatever, that's going to take this over in a different way. So we have to stand up and make sure that the primary care physicians are empowered and have the tools and resources they need to take on larger and larger amounts of populations. And remember what I said earlier, it can't mean that it takes them more time. It can't mean that it sacrifices them clinically, and it certainly has to bring them more dollars, and it has to be something that feeds their ego. Well, we can do that in what we're doing here. And so that moment in 2010, when I started to see that data, really started pushing us onto a vision that now here we are a decade later, and it's taken a crisis to push us to where I think we're within months of a completely new business model where primary care is the focus of the healthcare delivery system. I tell people all the time, because sometimes you'll hear things talked about gatekeepers and rationing care, and I think that those are old language. And we talk about PCP quarterbacks now, and it's a much more positive term. And this whole idea of rationing care, and I say, patients that are getting $80,000 of healthcare spent on them a year is not the same as spending $80,000 on vacations a year. The more you spend in healthcare, the less your quality of life is. And so if we can help those $80,000 or $40,000 cut in half because of better care coordination or asking better questions of what matters to them, other than always trying to tell them to quit smoking when there's other things that are compounding them that need to be addressed first, and maybe you get to smoking later. I'm not saying smoking's not bad for them, but if that's not where their first thought is, then you're going to have a hard time building a relationship with them. And so we want to make sure that people understand that it's not rationing care. It's just a better relationship that leads to a higher amount of well-being that, as a byproduct, will have a lower cost. And any lower cost that an individual has year to year in the healthcare means most of the time, by proxy, they're having a better year. And so that was kind of the evolvement moment in that 2010-11 timeframe, Jed, that allowed us to really just continuously improve and build upon where we are today.
So, Chris, could you comment on some of the data that you might have? You mentioned $100 million in savings. Do you have other key data that could help people to understand the performance of your system, like rates of people being hospitalized using the emergency room, those kinds of things?
Yeah, well, not globally, Larry, and the reason why is because we're in multiple geographies, and it depends on the population that you're talking about. I get asked a lot of times, like, what's your ratio of this or what's your ratio of that? And it really depends. Are we talking about the work we do on our elderly with Medicare and Medicare Advantage? Are we talking about commercial lives? are we talking about the rural communities that we're in? Are we talking about the urban communities we're in? Even in North Texas, I would tell you that the strategies we have to use in the ratios around hospitalizations and ER use and specialty procedures that are potentially unnecessary, the strategies we use in north part of the Metroplex area versus the south part of the Metroplex area are exactly opposite. We have to customize care. We call it intimacy at scale. And what we have to do is on the north side, for example, there's way too much care. We spend a lot of time from a care management, care coordination, using our relationships with the physicians and the patients and our tools to help people not get too much care on the north side. So hear that. We're trying to help people not get too much care on the north side because we can see just ridiculous amounts of spend on things that are potentially, whether it's back surgeries or, the 24-hour ER usage and things that too many catheterizations. A lot of medications that are brand that you have a lot of other substitutes, but there's lots of things up there on that side where there's just a plethora of higher socioeconomic, and where all the hospitals are being built in those areas, and so that's what we do there. You compare that to the southern part of the Metroplex, which are where some of the lower socioeconomic zip codes are. In those areas, we're actually trying to do everything we can around care coordination, our relationships to actually get people to basic care. So just 4, 5, 10 miles difference can be massively different. I would tell you there's a place called Fair Park in Dallas, Texas, where the Cotton Bowl is, that has a life expectancy of about 64 years old. Compare and contrast that with Highland Park, which is about 4 miles away, which has a life expectancy of 79 years old. So 4 miles, 15 years. So to say that, kind of what is our blanket ratios on things is difficult because of that geographical and socioeconomic context that we have.
Makes perfect sense. Allie, I'm going to bring you in. Do you have a question you might want to ask?
Hi, Dr. Crow.
There we go.
I was wondering, so when you finished your family medicine residency, did you envision yourself as helping to lead a health network, or what was your plan, and how did it evolve?
Thanks, Allie, because you're right there in that, in the middle of that. I certainly had no plan of spending all of that time and energy and money and $200,000 in debt to go to get into seeing patients to actually get out of it. That certainly was not my career path. It became evident to me that I was being called to something different in that 2011-ish timeframe when I was seeing some of this data of what the difference in costs were for independent physicians versus these health systems in the midst of mass consolidation across the country. And I knew, all I can say is, there's a lot around people finding their purpose in the 40-day purpose plan. I feel super fortunate that whatever it is that's inside of me, whether you call that God or spirit or whatever, is certainly spoke to me and continues to speak to me and drive me on days when I wish it didn't, to do something in the world that my one life was put here for. And so I continue to honor that and listen to that, even when, like I said, when I don't want to, and press forward. And one of my strengths and one of my weaknesses at times is my persistence, and that's what drives that persistence is a call. And so that these doors just became more and more in my life for me to walk through, and you walk through one and you walk through the next one. So, Allie, I don't know how to tell you that any differently other than that's the path that the world opened up for me, and it was not planned.
It's great that you followed it, though. Where in your career were you at that point?
I was leading let's call it a decade ago, I had, what I was known for back then, and a decade ago, is that I was leading a pretty well-known small group across the country called Village Health Partners. We were one of the first people on electronic medical records back a decade before that, and I had led a user group of Centricity, which is GEZMR, back in 2004 or 5 nationally. I'm not a technology guy at all, but I understand the power of using technology for business and automation and to inform. And we had grown to about, 15 or so, maybe 20 primary care physicians that we had already integrated our dietitians. We had integrated LPCs and social workers into our practice back in 2010. And we had grown a lot from back in 2003 or 4 when there was just 2 or 3 of us. That's a pretty big growth for that small of a practice. And so while everyone else was consolidating in the face of that, we were actually growing. And a lot of physicians were saying, "Hey, I don't want to go join the hospital. Can you help me out?" And we would do, quote unquote, soul biopsies on those people. And if they met our culture, which was similar to the culture that I've described already, then we'd bring them on and we'd try to figure it out. And we did. And what we also did is we built these medical villages back in the 2006, 7, 8, 9, 10 frame, and where you'd have these, and they're still in existence, where you'd have these single locations in the community rather than around a health center. So they're easy access and convenient, which is what I was mostly through 2010 trying to build, is access and convenience to primary care for the individual and the employer. We built these medical villages where primary care was the anchor tenant, and we'd surround it with specialists and services that you would expect and need from a primary care standpoint. And you'd had this geographic colo that created a really, really great experience and saved time, and people loved it. And that was our first, foray into medical home. And so we got a lot of press for those medical villages. But that was kind of an early, value-based care model that I learned a lot about in that moment, that allowed me to then pivot in 2010 and 11 to figure out how to put that at scale rather than just be a single site. Because for the large employers of North Texas, American Airlines, AT&T, et cetera, having a couple of sites in the northeast part of the county was cute, but it wouldn't really address the fact that there was 6 million people across 7 or 8 counties, and that are an hour and a half apart, that they would want to have access to in the same way. And so we had to rethink, and that became Catalyst Health Network.
Awesome. And I have one last question.
Okay.
Allie, we've lost you.
Where you're link something like this is not, person can't do it alone.
I'm sorry, Allie, you cut out for a minute, so I didn't get your question.
Oh yeah, can you hear me now?
Yes.
Okay, I was just wondering, I know that this would be really, really tough to do as one person alone. Who are your partners or mentors in building this network?
Yeah, so I'll name a few. Our co-founder is Lance Spivey. He had actually helped, he's a CPA kind of finance background. He had actually helped join Baylor Health Scott and White's network at an early age, and when they were just starting to employ physicians, and grew it all the way up to several hundred. And that helped him learn a lot about integrating physicians and the power of primary care, and then the things that they needed. And then he left it and became an independent consultant to do some of those same things for independent doctors. So he kind of was after the same heart, and he became a person that helped us at Village Health Partners as we were growing. And then he and I joined forces to create this. There's many other people along the way that have helped. Our current president of population health helped run independent pharmacies, 4,500 independent pharmacies across the country for McKesson, and before that, Target. And if you think about independent pharmacies and independent primary care physicians, there's a lot of similarities in those as small businesses. And so he's really helped bring some rigor and structure to what we do. We've had, I spend a lot of time in deep personal development with networks around the Stagen community. And you can kind of look up that for your viewers and listeners, which is a group of what we call conscious capitalists that are really trying to make a difference and use business as a force of good for good in the world. And so we think that businesses will only go as far as their leaders can take them. And so I'm constantly being pushed by them to build my own capacity and to build my own leadership skills to advance our company, which then advances hopefully our communities, which hopefully advances humanity. And so so those are a couple that I would say. I would point out who we've not received help from. We are super unique, and while Larry mentioned that we're one of a few that he's seen across the country that have been able to do this type of thing, I would say we're the only one that is doing it anywhere in this arena without private funding. I mean, without private equity. We are committed to a long-term play, and so to be able to commit to a long-term play, you have to be careful who your quote-unquote investors are. So we have, while every hospital, insurance company, and private equity firm in the country has hit us up, we've continued to try to say no. We've informed our physicians that that's a really important thing for us to be able to stave off as long as we can, because it allows us to play for the long. It allows us to be dynamic with our choices as things come up like this crisis, and not have somebody else's financial plan be our plan. And that's a really, really critical piece in a super minority existence right now in the country.
So we need to bring things.
Thank you.
We need to bring things to closure here, because the recording platform that I'm using will only allow us a few more minutes. So I would like to say, Chris, thank you so much for spending this time with us. And do I have your permission to share this broadly? I'm thinking of the American Academy of Family Physicians. I'm thinking of some organizations that I know of. People hearing this message, particularly over the next weeks to months, I think may inspire some of the change that you as a conscious capitalist are hoping to stimulate.
Yeah, please do. I'd love for you to send it to my team as well, Larry, because we can amplify this message. I'm doing that with everybody. Everything's freeware for me. We're working with Sean Martin and Greg Henley at AFP on a lot of things right now. They get a lot of our content. And we'd say, no pride in authorship. You want to cut and paste and make it yours, we don't care. We want to save as many people as we can. We think primary care physicians are the way to do that, and so we got to keep them. We got to keep them up on the front lines to do that. And it doesn't have to be just Catalyst Health Network. There's a bigger society play that we're all realizing we're connected to right now. So send it to anybody and everybody you think will be helpful, and I would just ask to include me as well, so I can amplify it in our channels.
Great. Thank you very much, and thank you for what you're doing. I'm just deeply impressed. And just a personal comment, I started in medicine a long time ago and stayed in medicine because of really the independent, the family physicians that I was working with, especially the ones who were in independent practice. And it's been a disappointment on my part to see so many folks sell to hospitals and healthcare systems. And you talked about the double price that a community pays when that happens. One of the things I'm hopeful that may happen yet in my lifetime is that there will be a resurrection of independent practitioners to help create the balance and the outcomes that are clearly evident in what you're doing. So kudos to you for what you've done, and thank you very much.
Yeah, you bet. And I will tell you that what we've built is the only way that can happen in the future, unfortunately, is that, the hospitals and the PE firms are going to be on a buying spree after this, we think. And that we think the individual practices are going to be scared to death. And there is not necessarily a path for a non-integrated independent primary care physician much further in the future. It doesn't mean they can't stay that way, but they're going to have to be integrated to some type of care delivery model like a Catalyst to be able to keep that existence. You're not going to be able to play all the way on the outsides by yourself anymore. It's just going to be too hard. And so we're hopeful that this serves as one of, maybe a few types of models that where doctors can get connected into, where they can still remain practice, but be part of something bigger. We call it the league and the team analogy, like the NFL and the teams. We're the league, right. They're the teams. That type of association is what's needed.
Well, when Elliot Fisher, I had a chance to have a extensive conversation with him some years ago, when he created the idea of accountable care organizations. What he had in mind was that independent docs like yourself would become the basis for the accountable care organizations. And what's happened is that healthcare systems, because they had
That's
access
right.
to capital,
That's right. You got it.
over that movement. And
that's right.
So what you've done is really create another option that hopefully others will be able to emulate.
You bet. All right, guys. Thanks for the time today.
Thank you very much.
Thanks.
You bet. Bye-bye.
Thank you. Bye.
So